This conference will now be recorded.
So from today onwards, what I'm thinking is I am going to do a short sessions daily on TOG articles, okay? Because you have seen from yesterday's exam that there are so many TOG questions, correct? So last 3 years there were so many questions on the TOG articles. So better to be familiar with these things. So today I'm starting from 2017 talks. So the first topic is cesarean scar ectopic pregnancy. Okay, actually this talk is why it is important just for the management type, management this thing, because the criteria is there in the guideline. Only the incidence and management is the important part from this talk. Okay, so you should know exactly what to concentrate on the talk, and then it will be easy. It's not necessary that you should reach each and every line from that talk. Okay, and if you do the strategy SBS from the top, these are, I think, well enough and just important points from the talks. Okay. So regarding this talk, so incidence of scar ectopic, it is 1 in 1800 to 1 in 2500. When there is one previous cesarean section and the ectopic pregnancy is there, then the incidence of scar ectopic becomes 6.1%. Okay. So when there is one previous cesarean section and the pregnancy is ectopic, the incidence of this scar ectopic becomes 6.1%. And if there is one scar ectopic, the risk of recurrence is increased, and the risk of recurrence is around 3.2 to 5%. Okay. And when they have been, and actually they have measured this incidence when this previous cesarean scar ectopic is treated by dilatation and curettage, okay, not by other surgical management, but when the previous cesarean scar ectopic is treated by dilatation and curettage, the recurrence rate is 3.2 to 5%. Why there is increased incidence in the recent years is because of increasing number of cesarean sections performed and the more diagnostic accuracy. So these are the reasons for this increased incidence. The pathogenesis for scar ectopic, as you know, there is a scar, so there will be disruption at endometrial and myometrium, and that will cause the scarring, and that scar results. So if there is invasion of this blastocyst through a microscopic defect, okay, so the microscopic defect of the scars, okay, in that if the blastocyst gets invaded, it results in scar pregnancy. But there is no clear correlation between the risk of scar ectopic and the number of previous cesarean. So it is not that if there is increased number of previous cesarean, scar ectopic pregnancy incidence increases. So there is no clear correlation between the number of cesarean sections and incidence of scar ectopic or risk of scar ectopic. But the relation is what they have found out for the scar ectopic. This you remember well. So the scar ectopic, they have found the relation with the cesarean section indication. So indication when the cesarean is performed for elective breach. Okay. So elective cesarean section for breach has been performed, then there is increased risk of scar ectopic. And the reason they are giving for that is because of the LUS is not well formed. So because of the higher incision on the uterus, that is responsible for this increased incidence of scar ectopic. So this is the thing that you should remember from this talk is that the increased risk of scar ectopic pregnancy is there when the cesarean section is performed, elective cesarean section has been performed from the or the breech presentation, okay, but there is no correlation between the number of cesarean sections and increased risk of scar ectopic. These are the two things that you should remember. Now, increased risk recurrence. So if there is one scar ectopic, what are the factors which are associated with increased risk of recurrence? So when the uterine thickness, okay, so uterine segment thickness is less than 5 millimeter, when the gestational sac is bulging in the UV fold, cesarean delivery is done in rural community hospital, and history of irregular vaginal bleeding and abdominal pain during previous cesarean scar pregnancy. So these are the factors they have found out for the increased risk of recurrence. Diagnosis, how you are going to do it? As you know, the main modality for diagnosis of cesarean scar ectopic is ultrasound. It is TVS ultrasound, and it is when the gestational stage is advanced, transabdominal ultrasound is also preferred. Okay, so combined transabdominal plus transvaginal ultrasound, it gives high accuracy, but TVS is the main modality of diagnosis. And when there is diagnosis is in doubt, you can do MRI also. Now this criteria, it is given in the GTG. There is nothing new that they have given. So criteria for diagnosis of ectopic, scar ectopic is empty uterine cavity and closed and empty cervical canal. Placenta or gestational sac embedded in the scar. Triangular, round or oval shaped gestational sac that fills the niche of the scar. A thin or absent myometrial layer between the gestational sac and the bladder. Yolk sac, embryo and cardiac activity. So it may be present or may not be present. Evidence of functional trophoblastic or placental circulation on colored flow Doppler examination, which is characterized by high velocity and low impedance blood flow. Okay. And the next important thing is negative sliding sign. So basically, negative sliding sign, the gestational sac embedded in the scar tissue and how it differs from cervical ectopic. So the barrel-shaped cervix is seen in cervical ectopic while this is absent. Okay, so how you are going to differentiate between the scar pregnancy and cervical pregnancies? There will be barrel-shaped cervix in case of cervical pregnancy, and here there will be no cervix will be normal and the pregnancy is embedded in the scar. Now the classification of scar ectopic, it is type 1 and type 2. So type 1 is endogenous. Type 1 means it is growing towards the uterine cavity. Okay. Implantation occurs in the scar and it grows towards the cervicoischemic or uterine cavity. And exogenous means the sac is embedded in the scar, but now the sac grows in the myometrium and grows towards the bladder. And this exogenic type is more dangerous because the myometrium layers get thinned out and there are chances that it will become thin and eventually disappear. So that sac will bulge and there is high risk of rupture. Okay, and in 2/3 of cases the thickness of scar is less than 5 millimeter. So exogenic type is more dangerous for the rupture, okay, and torrential bleeding. Now management option, there are various management options that has been explored for the cervical caesarean scar ectopic pregnancy, but the final is there is no consensus on the exact type of management. All treatment options, they carry a risk of hemorrhage and subsequent hysterectomy. The treatment of caesarean scar ectopic should be individualized, and the important thing is the pregnancy should be ended as soon as possible. Okay, because if you want to retain the future fertility, you have to remove the gestational sac and the scar pregnancy. Now, what are the options available? So there are so many options, right from the expectant management up to the surgical management. So just in short, we will discuss everything. So medical management, as you know, methotrexate. Methotrexate is a drug of choice. Now this methotrexate, what you can do, you can either give systemically. So systemically, the dose will be same, that is 50 milligram per meter square. And it is usually systemic administration is used alone, and just what you have to do is like tubal ectopic only, you have to monitor the beta HCG levels. And prior to administration of methotrexate, the woman should have baseline full blood count, liver and renal function test as per the GTG. Okay, this is the treatment is the better option when, so it can be used as a combined treatment before surgery also. So when the caesarean scar ectopic is exogenous type, and there are chances that it may carry surgical complications or it may be responsible for rupture. So what you can do is you can do it combined management also. So you can do systemic methotrexate and followed by the surgical removal. Now, another thing what you can do with this methotrexate is local injection into the sac or embolization. It is known as chemoembolisation. Okay, so methotrexate, potassium chloride, etoposide, hyperosmolar glucose, these all things can be used, but the methotrexate is the commonest drug to be used. You can give the injections either transabdominal or transvaginal, but transvaginal is preferred because it is anatomically closer to the target lesion and it also avoids visceral injury. What you can do is you can administer the methotrexate into the sac And finally, you can aspirate that gestational sac, okay? And along with that, you can do systemic administration, systemic methotrexate. So, IM methotrexate plus intralesional methotrexate, they in some studies they have shown to be have better outcome, okay, and they require fewer additional intervention. So, in the end, we will see for which scar pregnancy, which management to be given. Now, uterine artery chemoembolization. Here, same. You can do the uterine artery embolization along with either systemic or local methotrexate or with surgery also. So, this uterine artery embolization you can do either with methotrexate or with surgical management. And why this uterine embolization is done? To prevent the hemorrhage. But you can't use this uterine artery embolization alone, okay, because its role is uncertain. So either you have to use either with methotrexate or with surgery. Now surgery, you can do either evacuation or you can go for the excision. So surgical evacuation you can do for endogenous scar pregnancy, you can do surgical evacuation, but in that case myometrial thickness should be at least 2 millimeter. Okay, so the cases which are preferred for this evacuation, in those myometrial thickness should be at least 2 millimeters. So in that case you can go for surgical evacuation, but here there is high risk of bleeding and sometimes it is difficult to remove all the pregnancy tissue, and it should be ultrasound guided. Always it should be ultrasound guided to aid complete tissue removal, so that complete tissue removal will be possible. Usually what they do is with surgical evacuation, either they do systemic methotrexate or they can use they have used uterine artery embolization. Also to prevent hemorrhage, other techniques can be used like intrauterine Foley's catheter or Shirodkar suture. So Shirodkar sutures, what they do is they apply the Shirodkar sutures prior to suction evacuation. Okay. So just they apply the Shirodkar suture, but they will not tie it. So they will just take the suture, do the evacuation, and finally tie the suture so that it will arrest the bleeding. Okay. And this Shirodkar suture also avoids the risk of further interventions like uterine artery embolization. So it is it is useful for better fertility outcomes. Okay, so see, these in this talk, all these things what they have discussed is depend on the studies. There is not a confirmed management for the cesarean scar ectopic. So all these things they have not discussed in the DTG. Okay, which modality should be used. So in DTG they have not discussed all these management options in detail. In this talk they have detailed all these options. Now, another thing, for exogenous CSP, they can use abdominal or laparoscopic resection. So when there is the overlying myometrium is very thin, instead of surgical evacuation, abdominal or lap resection is preferred. Okay, it can be either done by laparotomy or laparoscopy. And usually the minimal invasive method, that means laparoscopy is preferred where the expertise is available. So the resection is done and the defect is closed. Also, there are it is advocated that you should ligate the uterine arteries along with this laparoscopic resection of the scar defect. Okay, to avoid the bleeding. So first you ligate the uterine artery and then resect this scar pregnancy. Also, transvaginal resection is also done. So where the advantage for this transvaginal resection is it removes the products of conception and scar tissue, and the closure of defect will be possible, and it is a minimally invasive technique. Okay, so the risk of adhesions will be less. Also, so what they have found out is closure of defect will be easier, and the risk of adhesion will be less as compared to the laparoscopic approach. Now, there are other things. So as I told you, they can use either combined. So combined or sequential modalities can be used. Now, what do you mean by combined? So combined management where more than one modality is used within a short interval. Okay, so either it can be used together or within a short interval. It is called as combined. So the most commonly used combined treatment option is uterine artery embolization or chemoembolization along with surgical procedure. So this is the most commonly used combined method. So you do either uterine artery embolization or intralesional methotrexate or systemic methotrexate along with the surgical procedure. Why it is used? To reduce the risk of bleeding, hysterectomy, and major surgery, and it allows quicker recovery and discharge. Surgical evacuation, what they do is surgical evacuation is usually performed after 24 to 48 hours after chemoembolisation. So this is good option for the woman presenting with moderate to heavy bleeding, because first you have to stop the bleeding. So first UA is done, or uterine artery embolization is done, and after 24 to 48 hours surgical evacuation. Now here there is no resection, but evacuation is done. Also, it can be this uterine artery embolization can be used as emergency procedure where the hemorrhage is severe. So here you can use uterine artery embolization first and followed by surgery. Also, hysteroscopic management can be done. So here what they are doing is usually they use as a primary treatment or sequential treatment. So sequential treatment means there should be some interval, some predetermined interval. So first they will give one treatment, one modality of treatment, then a predetermined interval will be there and another modality of treatment. So it is called a sequential. So here hysteroscopy can be used as a primary treatment, that means single treatment, or sequential treatment. Okay, so either first methotrexate or uterine artery embolization is done and followed by hysteroscopic resection. And this hysteroscopic resection is done to remove the persistent or remnant caesarean scar ectopic mass. If it is chosen as primary treatment, so here in that case, either uterine artery embolization should be done or laparoscopic uterine artery ligation should be done immediately prior to hysteroscopic resection to reduce the blood loss. Because here the most common danger with caesarean scar ectopic is it bleeds torrentially. If you have witnessed any scar pregnancy, you must be knowing that. The most common fear with the scar ectopic is it bleeds torrentially. Okay, and if we cannot control the bleeding, the woman requires hysterectomy. So to avoid that, so first thing is first priority is to arrest bleeding. So most commonly this uterine artery embolization is done to prevent the bleeding, or systemic methotrexate is done so that live ectopic is gone, so that the blood supply is reduced, and then you can do the surgical management. So sequential management, as I told you, there will be one modality followed by proper a predefined interval will be there, and then second modality is used. So in this approach, usually medical management is first used followed by surgical method. So why this sequential treatment is used? Because medical management may not always work even if you carefully select the woman, okay? And the woman may have continued symptoms of bleeding and pain which requires surgical intervention. Also, sometimes this remaining scar ectopic mass, it can develop into AV malformation or it can become infected, so that it requires additional surgical management. So beforehand only you can decide the treatment, like you have to give first medical treatment followed by some period of time like 2 weeks or 3 weeks, and then you can go for surgical treatment. So the benefit of this sequential treatment is it decreases the risk of hemorrhage with removal of the scar pregnancy mass and the shorter recovery period. So when the likelihood of a persistent ectopic mass is high, this sequential management can be used. Now, what about the expectant management? So I have not told this expectant management before because it has been shown that when the expectant management is used, this expectant management is used, almost 67% patient, they require further intervention, and of that 29% require hysterectomy. Okay, so usually the expectant management should not be used in case of scar ectopic. So here early intervention is always preferred for this all viable scar ectopic. But in very rare circumstances, when the scar ectopic is endogenic, okay, that means it is growing in the uterine cavity, and the patients who decline the termination of pregnancy because they think that there will be reduced fertility. So in that case, when the patient declines, expectant management can be taken as a compromised attitude, okay, it can be taken as a compromise. But Here you have to explain the patient regarding the risk of uterine rupture, hemorrhage, and possible hysterectomy at any time required. And this pregnancy should be closely monitored and planned cesarean delivery should be offered. Okay. Now, if there is heterotopic pregnancy in case of scar ectopic, so when there is a heterotopic pregnancy along with scar ectopic, what are the treatment options? So one thing is there are some study reports where they have shown that when the local injection of KCl or potassium chloride is given in the sac, the continuation of normal pregnancy can occur. Also, if the CSP is exogenous, it can be removed by laparoscopy and closure of the defect. Okay, so closure of the defect can be done simultaneously. That exogenous pregnancy, ectopic pregnancy is removed, but here there are chances that there can be increased risk of hemorrhage and abortion, that is losing normal intrauterine pregnancy also. So these two options, but that the preferred in case of endogenous pregnancy, local injection of potassium chloride will be the preferred management. So now, as I told you, there are n number of options. So how you are going to choose the option? Okay, so how you are going to choose the management plan? So expectant management, as I told, it is not generally recommended except in very rare situations where it can be done as a compromise. Medical management, it can be done in hemodynamically stable woman with minimal or no symptoms. Now remember this, minimal or no symptoms and hemodynamically stable woman, medical management can be done. Now, methotrexate is a drug of choice for medical management. And the criteria for methotrexate or it works best when the pregnancy is less than 8 weeks and SCG is less than 5,000. Okay, so these are the two things where the results with methotrexate will be better. So pregnancy less than 8 weeks, SCG less than 5,000. They have found out that intralesional injection of methotrexate, they have a higher success rate. Okay, and it can be considered as an option for hemodynamically stable women. Surgical treatment should be considered for women who have significant symptoms and those who decline medical management. The women who are having endogenous CSP, surgical evacuation or hysteroscopic resection, it carries less risk of perforation. While for exogenous scar pregnancies, surgical resection with resection should be considered. Okay. So for endogenous, evacuation or hysteroscopic removal, while for exogenous, it will be resection either by laparotomy or laparoscopy. When the expertise is available, transvaginal resection is also considered. And different combination of treatment that should be considered for scar pregnancies, where the scar pregnancies, they are of longer gestation and then the primary treatment is failed. Okay. So when the primary treatment is failed or the gestational age is more, here the combination of treatments like either combined management or sequential management can be considered. Now regarding the future pregnancies. So for medical management, it is like the GTG given, as in the GTG it is given, you have to follow up with beta SCG levels. Okay. Because when you do the medical management or surgical management, whatever, the scar arising after this scar ectopic pregnancy, it heals by fibrosis and there will be persistent defect. So before the future pregnancy, this persistent defect can be removed and closure can be done prior to the next pregnancy. But still there are many reports of these successful pregnancies after the medical or surgical management where the conservative management has been done. So where there is no removal of the scar tissue also, there are many reports of successful intrauterine pregnancy. So it is not always necessary to remove that scar defect and resuture it. But in future pregnancies, early ultrasound should be done to rule out any recurrence. Also, there is increased risk of adherent placentas, morbidly adherent placentas. So early diagnosis and investigation should be done for this morbidly adherent placentas. And what they have recommended is the future mode of delivery will be elective cesarean section. Okay, to reduce the risk of ruptured uterus and adequate closure of lower segment. So this is regarding the further pregnancies in case of scar ectopic. So this is regarding the TOG of scar ectopic, and these are the questions. These are the strategy questions. So you can just type in your chat box the answers of these questions. So a diagnosis of cesarean scar ectopic has been made in 23-year-old woman who had an elective section for breech presentation last year. She has been counseled and elected to have methotrexate. What baseline investigation should be performed? Now see what is the difference between C and D. So there is no lung functions are required. It is only full blood count, liver function and renal function test. Okay. So option is D. Answer is D. Good. Next one, 30-year-old woman who has been referred for early ultrasound scan and booking for antenatal care on account of past history that was complicated by emergency cesarean section that resulted in massive hemorrhage. She is 7 weeks pregnant by her LMP. Ultrasound scan is performed and this is suggestive of scar ectopic. Assuming that this diagnosis is correct, what would be the most appropriate initial treatment approach for this patient? Yes, it is systemic methotrexate. So there are so many options, but the evidence-based option is one is systemic methotrexate for early pregnancy and for hemodynamically unstable, it is surgical management. Okay, so answer here is D, systemic methotrexate. Yeah. So this is regarding this talk. Tomorrow we will see another talk. Okay. So bye for now.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you, ma'am.